Hi, my name is Clyde Yancy. I'm chair of the session on iron deficiency and heart failure as a part of the cardiometabolic health conferences. I'm joined by fabulous friends and peers to help me discuss these important issues. On my right is Gurusher Panjrath, who's in Washington, D.C. and directs the mechanical circulatory support team there. And on my left is Bykem Bozkurt, whom I've known for years, and she is chief of cardiology in Houston and is one of the leaders in cardiovascular medicine. Welcome to our discussion. Heart failure has become a very global disease entity. There was a time where we just thought about DASH diuretics and ACE inhibitors, and we knew there was something called HFpEF, but it was pretty straightforward. But it's much more involved now, and we have to deal with the comorbidities in a much more direct way. Some of the comorbidities, as you know, that we put in the recent guidelines address sleep apnea. Previous guidelines, we address atrial fibrillation. But importantly, there's new information that we've addressed about iron deficiency, really building out the portfolio of everything it takes to help a heart failure patient get better. Talk to me for a moment first, Bykem, about the importance of the comorbidities in heart failure.
It's probably one of our most important comorbidities in the sense that it affects a significant proportion of our patients. If we were to look at the studies, the prevalence ranges somewhere between 25 all the way up to 75%. Especially the sicker the patient gets, the higher the prevalence of iron deficiency anemia. And the other challenge is that it could be occult, meaning that the patient may not be even anemic, but may have iron deficiency anemia.
So what's so incredibly important about that is that if you focus simply on the ejection fraction and starting evidence-based therapy, which we espouse with great vigor, you miss these other dimensions of care which might improve quality of life, which might help patients feel better. And just as Bykem highlighted, Gurusher, many practitioners don't appreciate how prevalent these associated comorbidities are. Every time I look for sleep apnea, every time I look for iron deficiency, we find it. But it's important to understand the nuances of looking for iron deficiency. It's not just iron studies anymore, right?
Right, exactly. As you said quite correctly, the recognition of these comorbidities is the first step, and the spreading the word around about trying to recognize them, identify them, and diagnosis, because without that we still will be struggling on coming up with treatments if we don't know what the true prevalence of this is.
And most importantly, all three of us know that what our patients really long for is they want to feel better. They've already reconciled that their survival is going to be a challenge. And we help them with evidence-based therapies and devices to improve their survival. But what are the things we can do to help them feel better? In the symposium that we'll hold in Boston, which will be, I think, a great experience, there's several big objectives that we want to hit. What are those objectives, Bykem?
The first one is to diagnose. So we need to be able to screen, and I think currently the battery of tests that we do have allow us to be able to diagnose. So we can order the iron, the ferritin, and the transferrin saturation.
And that ferritin is important, right?
Ferritin is very, very important because it's almost like an initial screening in a diagnostic strategy is probably the best practical test the clinicians can order. The second step is to appropriately treat them. We should actively treat iron deficiency anemia. There will definitely be important benefits to the patient, starting with improvement in quality of life, improvement in exercise tolerance, functional capacity. Quality of life is one of the most important objectives of our patients. Thus, the treatment will result in improvement in patient-related outcomes.
Well, one of the really important things that we'll target during our symposium is to get away from the kind of glib, generic, let's just give them oral iron. We recognize that that is not the right approach, and we want people to come to the symposium not so they can get the short version, but they can understand the science behind why there is an approach that one should take to correctly treat iron deficiency. It may be other approaches that work, but for right now, all of us really embrace evidence as the way in which we should practice. The evidence really prompts us to use intravenous iron. We need to tell the group that attends our symposium in Boston how to do it, in which patient, how to make the diagnosis, and importantly, what the expectations are. Give me some closing thoughts, Gurusher, about iron deficiency and why it's important for individuals that are coming to Boston to take the time to come to our symposium. We think it's important, but tell the audience why you think it's important.
Right, I think it's important to us, it's more important to our patients, and that's why to help them improve the quality of life, as Bykem mentioned, and their functional class, their overall morbidity. We need to recognize what are the limitations on the current therapies, especially as you said about oral therapies, why they haven't worked and what's the pathophysiological basis behind it. And this is what we will discuss even in more detail at the conference. What are the strategies we can do to recognize iron deficiency in these patients? Because historically, some of the indices which we use are not very sensitive in picking them up, especially in those patients which do not have symptoms yet, but it may have a major impact on their quality of life if they were recognized and treated. So this conference will help us get an in-depth understanding of the mechanism behind it, what are the current strategies which are working, and where we are going with it.
So Gurusher, I really want to thank you because you really made it so incredibly clear with your first sentence. It's about the patients. If you're treating patients with heart failure, it's more than just the appropriate drugs and devices. Right. Gurusher nailed it. Come to the symposium so you can find another tool to help your patients feel better. Listen to experts in heart failure really talk about the whole portfolio of therapy, how important quality of life is, and give us an opportunity to enlighten you, to help guide the care of patients with heart failure. We look forward to seeing you in Boston at our Iron Deficiency and Heart Failure Conference. Thank you for your attention.